Hello, I'm David Hager. In this e-lecture, I will discuss the ventilation-perfusion relationships in the lung and how variations in these relationships can lead to hypoxemia. We will also discuss other mechanisms of hypoxemia that are not due to variations in VQ relationships. Here are the key points we want you to commit to memory. Number 1, understand pulmonary VQ matching and its relationship to oxygenation of blood. Number 2, understand the effects of gravity on the alveoli, blood flow, and VQ relationships. Number 3, be able to define shunt and dead space. Number 4, understand the consequences of VQ mismatch. Number 5, know the 5 causes of hypoxemia. Number 6, be able to calculate the AA gradient and how to use it. And number 7, be able to predict the response to increased FiO2 in the different causes of hypoxemia. Now, before we get to VQ relationships and hypoxemia, I wanted to review the alveolar gas equation. You've seen this equation before in Dr. Fessler's e-lecture on ventilation. It is an important equation that you should memorize if you've not already done so. In the context of this talk, it is important because it can be used to clarify the cause of a patient's hypoxemia. To summarize, the P big A O2 is equal to the difference between barometric pressure and water pressure that is added to the inhaled gas by the upper respiratory tree times the fraction of inspired oxygen minus P little a CO2 divided by R. R, or RQ, is the respiratory quotient, as you will recall. It is the ratio of carbon dioxide exhaled each minute divided by the amount of oxygen absorbed into the lungs each minute. This number will vary a bit depending on your diet, but with an average diet, and for the average person, and for the purposes of this course, we will use R equal to 0.8. This equation is used to determine the partial pressure of oxygen in the alveoli. As shown here, if you're breathing room air at sea level and have a normal P little a CO2, the P big A O2 is approximately 100 millimeters of mercury. The next step to getting oxygen into the blood is diffusion. This is a figure similar to those you saw in Dr. Wiener's lecture on diffusion. What you see is an idealized alveolus with a P big A O2 of 100, a P cap O2 of 45. As a result, there is a gradient of 55 millimeters of mercury driving the diffusion of oxygen from the alveolus into the capillary. Note also there is a gradient for CO2 to get out of the blood and into the alveolus. It is 5 millimeters of mercury. As you should remember, because the diffusivity of carbon dioxide is about 20 times as high as that of oxygen, we can get away with a much lower diffusion gradient for carbon dioxide. Now notice at the top of the figure, the PO2 at the end of the capillary is 100, and the PCO2 is 40. These are normal values and show that complete equilibration of each gas has occurred by the time the plasma leaves the capillary and enters the pulmonary veins. By definition, this means there is no diffusion defect for these two gases. The last piece of review that I think is helpful to recall for this lecture on VQ relationships and hypoxemia is the concept of oxygen content. Here you see 3 scenarios. First is the normal patient with a hemoglobin of 15 and a PaO2 of 100 millimeters of mercury. Using the oxygen content equation, you can quickly calculate that the blood content for this patient is 19.9 mLs of oxygen per 100 mLs of blood. However, if we put the patient on 100% oxygen, we see that hemoglobin is now 100% saturated, and there is a P little AO2 of 600 millimeters of mercury. Recall that because the partial pressure in the blood adds little to the total content beyond what is bound to hemoglobin, that the total content increases to only 21.9 mLs of oxygen per 100 mLs of blood. Lastly, you can calculate the content of venous blood and see that it is only 15.2 mLs of oxygen per 100 mLs of blood. This is a graphic description of these three scenarios. You've seen this figure previously in Dr. Wiener's e-lecture on oxygen and carbon dioxide. It shows you what you would expect in terms of oxygen saturation for any given PO2 in the blood, aka oxygen dissolved in the blood. Conversely, if you don't have the luxury of a blood gas, but you do have the percent saturation of hemoglobin with oxygen, you can estimate the PO2. Clinically, we are usually more interested in the arterial side, and with a pulse oximeter, we can easily estimate the percent saturation of hemoglobin with oxygen and can thereby estimate PO2 from this. In general, we like to see the arterial PO2 greater than 60 millimeters of mercury, which correlates with an oxyhemoglobin saturation of approximately 90%. This number is important because, as you can see, if the saturation is less than 90%, the slope of the curve changes dramatically, and small decreases in PO2 are associated with large reductions in oxygen content. Notice also that if the saturation is greater than 90%, the curve is flat. Increases in PO2 above 60 millimeters of mercury do not make a huge change in oxygen saturation or content. By the time the PO2 is 160 millimeters of mercury in this figure, the hemoglobin is 100% saturated, and dissolving additional oxygen into the blood, which you can do, will not lead to any additional binding of oxygen to hemoglobin. If we think about blood oxygen content in the calculations we've just reviewed, it follows that there is little to no benefit of supplementing oxygen once hemoglobin is 92% saturated. Okay, with that review, we'll move on to ventilation-perfusion relationships. There's a lot of information on this slide, which shows a single unit model of the lung. Focus first on the top left. You see tidal volume equaling 500 milliliters. The next thing you see is anatomic dead space. Recall from Dr. Fessler's e-lecture on ventilation that dead space ventilation does not contribute to carbon dioxide clearance. Now, with a respiratory rate of 15 and a tidal volume of 500, you can quickly calculate the minute ventilation, or V sub E, as being 7,500 mLs per minute. However, because of the anatomic dead space, the minute ventilation of the alveoli, or alveolar ventilation, V sub A, is much less. It's only 5,250 mLs per minute. You can easily calculate this by subtracting the dead space ventilation, 150 mLs times 15 breaths per minute, from the total minute ventilation. Now notice that the total blood flow through the lung is approximately 5,000 mLs per minute. So it turns out that the amount of alveolar gas that changes over through the course of a minute is almost equal to the amount of blood passing through the lungs in a minute. This gives you a VQ relationship, or ratio, of approximately 1. Now it is true that this is a conceptual model drawn to demonstrate what a VQ ratio is exactly. In real life, things get a bit more complicated. However, it is fair to say that for the majority of the lung, the VQ ratio is close to 1. In the average normal human, this results in an adequate gas exchange, carbon dioxide clearance, and oxygen uptake. You also saw this slide in Dr. Fessler's e-lecture on ventilation. It shows the relationship between transpulmonary pressure and percent total alveolar volume. Because pleural pressures are more negative at the apex in the upright person, the transpulmonary pressure at the apex is greater. As a result, the alveoli in this region are more open. Some alveoli may even approach their maximal volume. even at functional residual capacity. As a result, when the diaphragm contracts and drops the pleural pressure, it is the base of the lungs that has the ability to expand. It is a more compliant part of the lung. As a result, there is more ventilation to the lung bases in the upright person. Recall this figure from your E-lecture on circulation. I'll refer you back to the circulation E-lecture for a discussion of lung zones, but remember for now how flow of blood through the lung is affected by gravity. You can see from the right side of the figure that in the upright lung there is an effect of gravity on blood flow through the lung, resulting in more blood flow to the bases and very little to the apices. The message to glean from this and the last two slides is that VQ matching in the normal upright lung is pretty good, with a distribution of most of both ventilation and perfusion going to the lower portions of the lung. Here's a picture that nicely depicts what we've just reviewed. You can see that the alveoli at the apices are large, are approaching their maximal volume, and will therefore be less well ventilated. These alveoli are paired with capillaries that are narrow, with higher resistance, lower vascular pressures, and therefore less blood flow. The reverse is true at the bases. Given what I've just told you, you might now be thinking that the lung is constructed to perfectly match ventilation and perfusion. When this has been assessed, it turns out that the relationship is not perfect, but it is pretty good. In this figure, you see rib count along the x-axis, starting at the bottom of the lungs on the left and going to the top on the right. On the left y-axis, you have alveolar minute ventilation or lung perfusion. Though the lines depicting ventilation or perfusion as we move from the bottom of the lungs to the top of the lungs do not overlap perfectly, you can see that what we have just reviewed is generally true, with more ventilation and more perfusion occurring at the lung bases. On the right y-axis, alveolar ventilation to perfusion ratio is plotted. Here you can see that as you get to the top of the lung, the alveolar ventilation to perfusion relationship becomes quite high. That means that those lung regions are being ventilated far in excess of their perfusion. By contrast, you can see that the majority of the lung has an alveolar ventilation to perfusion ratio ranging between 0.8 to 1.1 or thereabouts. This slide depicts two extremes of the VQ relationship as well as the normal. Shunt is depicted on the left, where the VQ ratio equals 0. Dead space on the right shows a VQ relationship equal to infinity. It is worth taking a moment to look at the alveolar PO2 and alveolar PCO2 in each of these scenarios. For shunt, the values in the alveoli equal the values in the blood returning to and leaving the lung. No gas exchange has occurred. In the normal, there is equilibration between the alveolus and the blood leaving the lung, i.e. no diffusion defect. And for dead space, there is no blood flow to the lung, so alveolar air reflects humidified atmospheric air with an alveolar PO2 of approximately 150 and a PCO2 of 0. Of course, the reality is that we don't just have three situations. We have 300 million alveolar and capillary interfaces along a continuum with a broad range of VQ relationships. Here you see this depicted by a curve showing all the physiologically possible combinations of PO2 and PCO2 in the pulmonary capillary blood, with shunt on the far left and dead space on the far right. Here's the same curve, but we now show how height of the lung alters VQ relationships. We also show you two extremes. On the left, you see an arrow drawn from the far left of the curve to the heart. This is the data you would see in the setting of a patent foraminal valley or a hole in the heart. Another name for this, of course, would be shunt, where you have blood returning to the right side of the heart, going through the heart, and then out to the left-sided circulation, fully bypassing the lung. On the right, you see an arrow that's drawn from the x-axis up to the trachea. The trachea, of course, has no alveolar capillaries, and no gas exchange occurs. So this would represent dead space. Okay, so that was a fairly long introduction with a lot of background review. Hopefully it will facilitate your understanding of the subsequent discussion of hypoxemia. Before we get too far, I just wanted to clarify a bit of nomenclature. Hypoxemia is a specific term which indicates inadequate oxygenation of the blood. It means the partial pressure of oxygen in the blood is low. This is a specific definition. Hypoxia, which frankly is frequently used interchangeably with hypoxemia, actually indicates insufficient tissue oxygenation, and it is a nonspecific term. For the purposes of this lecture, we're very focused on how the blood fails to be oxygenated when passing through the lung. So we're actually talking about hypoxemia. Okay, so here are the 5 causes or mechanisms of hypoxemia: shunt, VQ mismatch, diffusion defect, hypoventilation, and decreased atmospheric oxygen, as would occur at altitude. Altitude is easy to deal with. If you're on the top of a mountain, up in a plane, or happen to be in a room with low FiO2, the amount of oxygen you inhale will be less than normal. On the top of a mountain, FiO2 is still 21%, but 21% of a lower barometric pressure gives you a lower inhaled partial pressure of oxygen. If you're in a room with a low FiO2, this will also give you a lower inhaled partial pressure of oxygen. This could happen in the context of a fire, when oxygen has been consumed, or in an industrial accident in which some other gas like nitrogen is released. Look at the alveolar gas equation again, and you'll see how this works immediately. The other types of hypoxemia require a little more explanation. To think about hypoxemia, we'll start with this ideal 2-unit model. You see venous blood returning to the lungs with a pVO2 of 40 and leaving the lungs, quote-unquote, arterialized. Arterialized is probably not the best word here because blood leaves the lungs via the pulmonary veins en route to the left atrium. However, the intent is to convey that the blood leaving the lungs should have a similar PO2 and PCO2 as that in the systemic arteries leaving the left ventricle. In this figure, ventilation and perfusion are perfectly matched, and each unit has a ventilation-perfusion relationship of 1. As a result, blood leaving the alveolar capillary interface has a PaO2 and a PaCO2 equal to that in the alveoli. Now, if we were to consider a shunt, how would this figure and the numbers change? One way to create a shunt would be to completely occlude the left-sided airway. Think about how this would alter the arterialized blood. In this case, the left-sided airway is completely obstructed to cause a 50% shunt. As a result, the gas remaining in the alveolus distal to the obstruction would be in equilibrium with the gas in the venous blood returning to this portion of the lung. And because there is no gas exchange, the PO2 in the blood leaving the alveolus would be unchanged. So here is where many people get confused. When the blood coming from the left and right are mixed, we cannot just average the PO2s. Remember that the oxygen-hemoglobin dissociation curve is important. As soon as blood from the right mixes with blood from the left, some oxygen bound to the fully saturated hemoglobin from the right will detach, and it will bind some of the poorly saturated hemoglobin coming from the left. This will occur until all hemoglobin is equally saturated and in equilibrium with the oxygen dissolved in the blood. In general, you can figure this out by averaging the percent saturation of the hemoglobin coming from the 2 different sources. Here, the right and left units. You can then look at the oxyhemoglobin dissociation curve and get a sense of what the PO2 should be. Remember this figure from earlier in the lecture. We know that normally venous blood returning to the heart has a hemoglobin oxygen saturation of 75%, which corresponds to a PVO2 of 40 millimeters of mercury. If you consider this figure in relationship to the previous slide, you can quickly see why shunt can create hypoxemia and why it is particularly challenging to manage unless you can get rid of the shunt. I'll mention PEEP here as a way to reverse shunt, as is observed in ARDS. Stay tuned. Other conditions that cause shunt are as follows: lobar pneumonia, pulmonary edema, as can occur from congestive heart failure, foreign body obstructing an airway, or hole in the heart leading to right to left shunt. You may have heard of the blue baby syndrome, made famous at Johns Hopkins. Another more common example would be a patent foramen ovale. You may remember that from your anatomy class. VQ mismatch or imbalance is the next cause of hypoxemia we'll consider. Note that low VQ units cause hypoxemia. By contrast, high VQ units do not cause hypoxemia. Further, they cannot counteract the hypoxemic effects of low VQ units. You may be thinking that I just told you shunt is the extreme of low VQ. So the hypoxemia in VQ mismatch is understandable, right? Well, I'm going to tell you that the hypoxemia of low VQ is relatively well managed with supplemental oxygen. Let's first consider why low VQ that is not shunt causes hypoxemia, and then later we'll talk about how it responds to supplemental oxygen. In this example, there is an airway obstruction, but it's not a complete obstruction. As a result of relative hypoventilation, less fresh gas or oxygen-rich inspired gas gets to the alveolus. The result is that the P big AO2 of the alveolus on the left is lower than normal. On the right, if overall alveolar ventilation remains constant, you'll have a VQ ratio of greater than 1, which means that the P big AO2 on that side will be higher than normal. The result is that the blood leaving the left has a PO2 of about 50 millimeters of mercury, and the blood leaving the right has a PO2 of 110. As we discussed a few slides ago, when this blood mixes, the fully saturated hemoglobin from the right will mix with a partially saturated hemoglobin from the left. There will be a net transfer of oxygen from the fully saturated hemoglobin molecules to those that are only partially saturated until a new equilibrium is established. In this case, the equilibrium occurs at a saturation of 90%. And this corresponds to a PO2 of 60 millimeters of mercury. As in the case of shunt, it is the average of the saturations, not the PO2s. The higher PO2 in blood from the overventilated regions does not add much oxygen content to the final mix. Here's a list of conditions that are known for causing hypoxemia from low VQ mismatch. The common theme is obvious: airways obstruction. They include asthma, COPD, bronchiolitis, airways lesions such as tumor, foreign body, and cystic fibrosis. Okay, what about diffusion defect? This usually does not cause hypoxemia at rest, but as you will recall from the E-lecture on diffusion, anything that increases the rate of blood flow through the lungs can unmask a diffusion defect. Though the alveolar ventilation is normal here, and as a result the P big AO2 is at the expected level of 100, the unit on the left has a diffusion defect, as indicated by the lack of equilibration of PO2 between the capillary and the alveolus. So, like with VQ mismatch and with shunt, when this relatively deoxygenated blood mixes with the blood from the right, the end result is borderline hypoxemia, even though the right-sided unit is working normally. Some examples of diseases where the DLCO may be reduced include interstitial lung disease, sarcoidosis, atypical pneumonias such as pneumocystis, pulmonary hypertension, and pneumonectomy. In each of these cases or entities, there is a significant loss of surface area, so diffusion is decreased. Look back at the diffusion lecture if this does not make sense. It's important to get it straight. The case of reduced P big AO2 is easier to understand. Here you have two units with perfect VQ relationships. However, if the inhaled gas is low in oxygen, the P big AO2 will be low. It follows that less oxygen can diffuse into the capillaries. This can result in hypoxemia. So I mentioned earlier that altitude can lead to this situation. What else can? Well, the more common cause leading to new hypoxemia is hypoventilation, as might occur following a narcotic overdose, a stroke that affects the respiratory control center of the brain, or asphyxia. Both hypoventilation and decreased inhaled oxygen are easily identified causes of hypoxemia based on the presence of a normal AA gradient. Again, remember that alveolar gas equation. It will help you. Here's an example of how hypoventilation leads to hypoxemia. Just work through the numbers and you will see that in the hypoventilating patient who has a P little a CO2 of 80, that the resultant P big AO2 is 50, which is the best PO2 the capillary blood leaving the lungs will have in the absence of supplemental oxygen. So how do you calculate the AA gradient? To do this, you need to know the P big AO2, and we've gone through how to calculate that using the alveolar gas equation. From P big AO2, you subtract P little AO2, which you can get from an arterial blood gas. You should know that a normal AA gradient is about 20 millimeters of mercury. If the AA gradient is not normal, meaning that it is higher than normal, then hypoxemia cannot be from hypoventilation or decreased inhaled oxygen. It must be due to either shunt, VQ mismatch, or diffusion defect. Now, let's go through the different causes of hypoxemia and see how they respond to supplemental oxygen. Here is the patient with two normal lung units breathing an FiO2 of 0.5. You should go through the calculations yourself, but you should find that the P big AO2 is approximately 300 millimeters of mercury. In this picture, you have perfect diffusion, so the P little AO2 also ends up being 300. Here is the case of shunt in the setting of supplemental oxygen. You can see based on this why shunt is so challenging to manage. We could give this patient 100% oxygen, but they would still only likely have a P little AO2 of 60 to 65 millimeters of mercury. Again, the high PO2 coming from the non-shunt regions does not contribute much to the oxygen content in the final mix. Hypoxemia from shunt is very refractory to supplemental oxygen. By contrast, with VQ mismatch, use of higher FiO2 ultimately leads to a higher P big AO2 even in alveoli that are not well ventilated. Given enough time breathing supplemental oxygen, even poorly ventilated regions eventually increase their alveolar PO2, as shown on the left here. And because hemoglobin is fully saturated at a PO2 of approximately 90 millimeters of mercury, hypoxemia from VQ mismatch is easily managed. Note that because the hemoglobin is 100% saturated leaving the alveolar capillary interface, you can now get away with averaging the PO2s. As a result, the PO2 leaving the lungs in this case is 255. Lastly, in the patient who is hypoxemic from a diffusion defect, supplemental oxygen leads to a higher partial pressure gradient for oxygen across the alveolar capillary interface. As a result, more oxygen gets into the blood, as depicted here. Okay, take a deep breath. Here is a summary of what we've covered. Oxygenation of blood is optimal when ventilation and perfusion are matched 1-to-1. Regional ventilation and perfusion increase in the lung from apex to base. Shunt, which causes hypoxemia, is defined as perfusion without ventilation. Dead space, which causes hypercarbia, is defined as ventilation without perfusion. Areas of low VQ contribute to hypoxemia. The 5 causes of hypoxemia are shunt, VQ mismatch, diffusion defect, hypoventilation, and decreased environmental oxygen, as could occur with being at altitude. Hypoxemia with a normal A gradient is due to reduced environmental oxygen or hypoventilation. And lastly, all forms of hypoxemia respond well to increased FiO2 except for shunt. Hope this lecture has been helpful both in terms of review and in your understanding of hypoxemia. Please let us know if you have questions.